Hello, and thank you for taking time to listen to me. What I am about to present here is the work that I have been doing for my PhD with the guidance of my wonderful supervisors, Ali and Antonia, at the School of Health of Victoria University of Wellington. In a nutshell, my research is about understanding what is needed to improve primary health care for trans and diverse people. While primary healthcare also includes transitioning-related gender-affirming healthcare, the focus of this research is on the experiences of people when seeing a GP or a patient for the more general aspects of primary healthcare, which might or might not be related to aspects of a person's gender identity. The topic of my research, the title of my research is An Exploration of Primary Healthcare Provision for Trans and Gender Diverse People in Aotearoa, New Zealand. But before I start, let me tell you a little bit about myself. My name is Sandra, and I am a cisgender woman and a lesbian, so I am part of our beautiful and diverse rainbow community. I come from Brazil, from a lovely place up north called Salvador. In terms of my ethnicity, I am a mix of indigenous, African, and Portuguese heritage. I left Brazil around 15 years ago to come to New Zealand, where I stayed just a year before I moved to the UK. So in England, I did an undergrad in psychology and counseling and a master's in health psychology. I was lucky enough to travel back to New Zealand just before our first lockdown to start my PhD. And I'm really happy to be here, and I have no doubt in my mind that I came to the right place. So enough about me now, let's move on. I have made a little glossary here for those who aren't very familiar with some of the terminologies that I'm going to be using here today. But I'm going to start by giving you a brief overview of this research background so you can understand why doing this research is important. Then I'm going to outline the methodology and theoretical framework that I am using. So the issue and why it is important. In New Zealand, many people are trans and gender diverse, and this number is growing really fast. Trans and gender diverse people tend to have poorer overall health when compared to people within the general population. And this has been linked to experiences of stigma and discrimination that people face in society at large, but also due to a number of other barriers that prevent people from receiving the type of primary health care that can cater to their needs. There are many ways by which experienced discrimination can lead to poor health outcomes. One of them is through avoidance of healthcare for fear of discrimination. Another one is linked to constantly being worried about being a target of discrimination, which is a source of anxiety and stress in its own right that directly affect people's health and well-being. So the role of GPs in New Zealand, GPs tend to be the very first healthcare provider that people go to when they're not feeling very well. So when it comes to the healthcare of transgender and diverse people, GPs provide general healthcare as they would for anyone. But for people who don't desire to medically transition, some GPs will prescribe and manage gender-affirming hormones. Others will provide referrals to endocrinologists and mental health care providers. GPs are also responsible for looking after people's overall health when they are undertaking gender-affirming treatment. So the role of GPs when it comes to the care of trans and gender diverse people is very varied, but also very important. So what we know so far in terms of the experiences of trans and gender diverse people with GPs internationally here in New Zealand is that people report a range of positive and negative experiences. So positive experiences usually happen when GPs use people's right name and pronouns, when they are knowledgeable about people's health needs, when they are able to facilitate ways by which people can self-identify, either by asking or by providing intake forms, when GPs encourage people to participate in decision-making with regards to their own health. Unfortunately, some experiences are perceived as negative, and that usually happens when GPs didn't know much about people's about transgender health when GPs misgendered people or asked questions that were seen as irrelevant to the clinical encounter, when GPs engaged in moral disciplining, or when they refused to care, and that usually happened due to lack of knowledge or unwillingness to prescribe or manage hormones. These experiences are very harmful to people's health. So what is preventing people from receiving and delivering appropriate primary health care? Let's have a look at what we know so far in terms of barriers to care. So the first thing that seems clear is that future doctors receive very minimal to none LGBT education throughout their undergrad, between 0 to 5 hours. Some explanations have been put forward, such as lack of time to include transgender health in medical students' curricula, such as lack of teachers to teach the topic, lack of understanding of the best ways to teach transgender health. The literature also indicates some other barriers, existing barriers that might reflect some of the challenges and dilemma in this field. The first one you can see turning blue right now seems to impact healthcare providers' willingness to play a more active role when it comes to transitioning related gender-affirming healthcare. The second one you can see turning blue right now seems to impact how gender diversity is portrayed within healthcare. For example, as of today, gender diversity remains a diagnostic category in the DSM and the ICD, and the diagnosis of gender dysphoria is usually required for people who want to access a gender-affirming treatment. But historically, diagnoses in the DSM and the ICD have framed gender diversity within a discursive condition, disorder, and more recently, psychological distress, which in effect pathologizes transgender experience. So the dilemma seems to be that while the existence of diagnosis secures access to medically transitioning healthcare, it also perpetuates the notion of gender diversity as a pathology and stigmatizing gender diversity. So what are some of the immediate consequences of these barriers that we just talked through? So lack of inclusion of transgender health into medical student curricula means that future GPs haven't had the opportunity to self-reflect, to challenge their worldviews, such as the idea that every patient they meet will be cisgender. It leads to poor general healthcare experiences, simply because GPs aren't able to recognize matters that are important to the health of transgender diverse people. It leads to GPs who lack knowledge and willingness to clinically manage transitioning related gender-affirming healthcare, and which ultimately leads to denial or delay of access to gender-affirming hormones and surgeries through further referrals. So to bring it all together, there is an urgent need to improve primary health care for trans and gender diverse people in New Zealand. Only one study and one qualitative study have looked at both groups, GPs as well as people who are gender diverse. What it means is that we need more research that can help us understand what Takatapui and other trans and gender diverse people in New Zealand need and expect from their GPs, as well as what is required to support GPs in providing this type of care. So hopefully this research will provide key information to help us to achieve this. So these are my research aims: to explore the experiences of people receiving and delivering primary health care, to identify the strengths and barriers to primary health care for trans and gender diverse people, to identify the steps to move forward primary health care for trans and gender diverse people. Methodology. So I'm going to carry out 2 qualitative studies, one with GPs, another one with with people who are gender diverse. I'm going to use interview as my mode of data collection and discourse analysis as my theoretical and analytical framework. I've just been granted ethical approval to carry out this project. Happy days. And I'm going to be working with a lovely group of people who are gender diverse, also people who are GPs, also people who are GPs and gender diverse, who are helping me to ensure that this research reflects the needs and concerns of both groups. I am also receiving the help of Dr. Clive Aspin, who is providing cultural advice for this research. Okay, so in terms of theoretical and analytical framework, I'm using discourse analysis, and I've based my decision for choosing this approach because language is central to all social activities. It is our main mode of interaction. So it is through language that we attribute meaning to our experiences, that we construct common knowledge, that we position ourselves in relation to others, in a way that establish power relation. So our hope is that by examining language, by examining discourse, by understanding how discourse plays out within the topic of primary healthcare, it will give us an indication of what is needed to improve primary healthcare for people who are trans and gender diverse in New Zealand. So I think that's all for me. I hope you have enjoyed it. I'm really looking forward to our discussion. Yeah, that's it for now. Thank you very much for listening, and ciao.
Tēnā koutou katoa. E mihi ana aho ki ngā tupuna me ngā tupuna ira whiti hoki. I whana mai i te note o Amerika, ki Aotearoa toku kāinga i nei, no Europe o ku tupuna I whaingia o ku tupuna te whenua o tūraki note o Amerika. Ko tēnei taku mihi ki ngā tangata whenua o Erawahi, ko kahi toko ingoa, no reira tēnā koutou katoa. So my name is Cassie, and I am living in Dunedin, Aotearoa. Currently, I'm originally from the United States, and my ancestry is European. I just wanted to acknowledge both the indigenous peoples of all of these lands that allowed my ancestors to thrive at the expense of other people, and also to acknowledge our tupuna, the ancestors that came before us, whether they be our blood relations or our transcestors. Today, I'm going to be presenting on my master's in public health thesis research at the Department of Preventive and Social Medicine, and my supervisors are Dr. Kate Morgaine in Preventive and Social Medicine and Associate Professor Gareth Traharn in the Department of Psychology. I'm going to be talking about the positive experiences of transgender and gender diverse adults with their primary care physicians today. And we decided to frame the research this way because we wanted to inform best practice with what worked rather than what did not work. And as always, transgender healthcare research is timely and potentially life-saving. For the population description, I really wanted to make sure that we included all the wiggly bits at the edges of our communities. And so we made it very explicit. Anyone of any gender identity that differs from what they were assigned at birth were welcome to participate. And we explicitly named people with non-binary gender identities or a lack of gender identity, Māori identities such as whakawahine or tangata iratane, and this included adults of any gender expression or with or without a history of medical transitioning. So to do recruitment, it was two-staged. I did an online eligibility questionnaire, which was just quite short. And then from that, I recruited people, 11 participants did semi-structured email interviews, and I asked them about their positive experiences engaging with primary care. The data from those email interviews was analyzed using thematic analysis, and this was a really great opportunity to use qualitative research and really get some deep insights into what people experience engaging with primary care. So I have a visualization of some of my results. I had 3 main themes that I found in the email interview data. No matter how I focused on positive experiences. People always brought up in their interviews the sad state of healthcare for trans people in New Zealand. This quote here kind of exemplifies that conundrum. I feel like I'm mostly complaining about bad things rather than focusing on the good. I guess it's because it seems legitimately ridiculous to just type things like, it's been a good visit to the doctor, when he knew more about medicine than me, without qualifying that. So participants experienced a lot of negative interactions with their healthcare providers and the healthcare system more broadly. And so even though we were asking about those positive experiences, those were contextualized within this larger experience or expectation of negative outcomes. The second theme is the sphere of control. And it's the fact that no matter how unfortunate the sad state of care was, transgender participants all talked about the ways that they could self-advocate or try to improve the chances of having a positive experience with a general practitioner. So that included ways of preparing themselves or mitigating expectations or crowdsourcing information and getting recommendations on who might be a positive provider. This quote here, you can see it says, I only got the bare minimum of care. I asked around the internet to try to find another GP. I had appointments with a couple of them, but the third was a breakthrough moment. So you can see how transgender people are in this situation where they're having poor health outcomes. They're having a lot of barriers to care. They're having negative experiences, but they're still doing lots of things to try to have those positive experiences, trying to figure out a way around this. The final theme has 3 sub-themes, and it's the gradient of positive experiences. So this is actually what the research question was trying to find out. And it's broken down into basic doctoring, better practice, and next level support. And I tried to kind of situate it here so you can see how a lot of this gradient of positive experiences is still situated within this sad state of care. And it's just like kind of stair-stepped up into, beyond that, the next level support. Hopefully move beyond the sad state of care. So basic doctoring was things like respecting people's pronouns, not being mean to them, just generally basic professionalism. And the better practice had a bit more to do with people who either knew about transgender specific healthcare needs or who had put forth the kind of effort to make sure that they would go on to upskill themselves and show their patients that they were interested in learning about the things that they didn't know about transgender health. The next level support theme was more about doctors who were doing things as advocates within the wider community or within the healthcare system to try to improve pathways to care or improve transgender health outcomes. This quote here, at my GP's office, they have posters on the wall about gender, sexual diversity, which is a positive because it lets me know the staff are already going to have an understanding of transgender healthcare. So this is just one indication of how visual signaling was a way that people could indicate to patients that the people who worked at a clinic or in a doctor's office or a hospital knew that transgender people existed. And that was often a really good starting point to have some of those conversations about their healthcare needs and to put them at ease. So this research that I've done, my findings match the literature. There's barriers to healthcare, poor health outcomes, and health inequities. I think we all know that that's pretty universal. The sphere of control theme stood out to me because while it was supported by the literature, it wasn't always named explicitly when transgender people were kind of doing these things of their own volition to try to improve their opportunities to have positive experiences in healthcare. And so in my thesis, I proposed a new term, reactive self-determination, as a way of specifically naming that transgender people are taking these actions in reaction to systemic barriers, to systemic oppression, specifically, and trying to make something of the situation. They're exerting self-determination and autonomy and agency in the face of all of these barriers to doing so. And I think that it's important to have this term as a way to not only acknowledge how much really amazing effort transgender people have put into taking care of themselves and trying to advocate for themselves, but also acknowledging that systemic aspect, that if that systemic aspect wasn't there, people probably wouldn't have to put all this work into fighting against it. And there isn't a lot of literature around positive experience in healthcare, but I think that what is there kind of supported that idea that there's quite a gradient of what might be considered a positive, depending on the person, the healthcare situation, the context, their personal experiences, etc. So going forward, really wanted to focus on ways that we could practically apply some of these findings. And systemic issues always need systemic solutions. So while a lot of this stuff is going to be quite high level, there are some suggestions for best practice that primary care providers can take on themselves. And that has to do with adhering to best practice around professionalism, kindness, and trans awareness, which can go a really long way to having creating positive experiences for transgender patients. Allowing for experiential authority and allowing relationships between the doctor and the patient to be collaborative is often a way that people find experiences to be positive. And possibly using the power that doctors and healthcare providers have within the medical system to advocate for changes. And one of my other recommendations is that strengths-based frameworks are great for research and, as always, should be informed by the community. Aside from that, some of the bigger level stuff or higher level stuff, I think would be changes to medical school curriculum, which I feel like a lot of people here already support, potential pathways to increasing access to knowledge. So making sure that doctors can actually upskill themselves on transgender health issues or be aware of what the pathways to medical transition are. And some of those that might be through online portals, continuing education, professional development, et cetera. And especially in light of COVID, as always, urging people to consider telehealth options, which are great for a range of people, including transgender and gender diverse communities. Real quick, I just want to say thank you to my supervisors for their support in conducting such a personal and at times difficult research project. And mostly to my participants for being so generous and providing their time and being willing to discuss these profoundly personal experiences with me so that we can work together to hopefully improve health outcomes for all of our communities. And my email is there if anyone has any questions that they would rather not ask me in the Q&A. Thank you.